traveling from Hassan to Kalaburagi via Mudhol and Tumkur, because we have the moderators from Mudhol and Tumkur. Dr. Chandrashekar will be joining. Again, ಸ್ವಲ್ಪ echo ಬರ್ತಾ ಇದೆ. Deeksha.
Yes, sir.
Yeah, now it is not there. So I welcome our chairman, Dr. Naz Jahan Sheikh, for today's program.
Good evening, everyone.
Every month, in past so many years, we are doing the PG time, benefiting the PGs and also refreshing ourselves also. I welcome our chairman and I request her to start the program. Madam, please.
Yes. Good evening, everyone. Respected dignitaries of KSCASI, in the immediate past president, Dr. Rajgopal Shanai, the Director of Academic Council in his absence, past president of ASI and Director of Social Service, Dr. G. Siddesh, again in his absence, Chairman-elect Dr. Rajshekar C. Jaka, our vibrant EC members, Dr. Anand Kumar, Dr. Savitha, Dr. Sangmesh, and our secretary, Dr. Sarvesh. And today's moderator, today is the fourth PG time we are conducting. And the moderator for today is Dr. Savitha Karlwad and Dr. Chandrashekar N, who will be joining us a little later. And then the examiners are Dr. Ravi S, HOD, Department of Surgery, HIMS Hassan, Dr. Savitha SK, Professor and HOD of KIMS Karwar, and Dr. Shashikumar HB, Professor and Head of the Unit, MMCRI. And I must tell you here that we are very thankful to you for accepting an invitation at a very short notice. And our presenters are Dr. Deeksha, final year PG from HIMS Hassan, and Dr. Vishal Patil, second year PG, GIMS Kalaburagi. We welcome you all to this program and we wish you all the very best. I would like to take this opportunity to thank each one of you present here and all the participants for the Surgeons Week. Everybody has done exemplary work for this week, and each one has shown the presence that they are so important in the society, and the Surgeons Week has really gone on very well. Thank you all, and I request you to go proceed with the meeting. Over to you, Dr. Sarvesh.
Hello.
Yeah. Okay.
Yeah. Thank you, madam. We'll hand over the thing to Dr. Savitha.
Yes.
Madam, please. Moderator, Dr. Savitha.
Good evening, everyone. So I'm happy to moderate this session of today's PG time. I welcome the examiners and I also examiners Dr. Ravi from HIMS Hassan, another examiner from KIMS Karwar, Dr. Savitha SK, and another examiner from MMCRI Mysore, Dr. Shashikumar HB, Professor and Unit Chief. Sir, with all your permission of the examiners, shall we start the first presenter, sir? So I would like Dr. Deeksha, final year PG from Hassan, to present the case of midline neck swelling, multinodular goiter. Deeksha, kindly present your case.
Yes, yes, ma'am. Good evening, all. I am presenting a case of a 42-year-old female hailing from Holenarsipura, Hassan, homemaker, and was admitted on 13th of June 2026. She presented with the chief complaints of swelling in front of the lower part of neck since 2 years. Patient was apparently all right 2 years ago, after which she noticed the swelling in lower part of front of the neck, which was initially 2 centimeter and has gradually progressed to a present size of 5 centimeter. There was no history of pain, there was no history of fever, no history of difficulty in breathing or stridor, there was no history of hoarseness of voice, there is no history of difficulty in swallowing, no features which is suggestive of hypo or hyperthyroidism. There are no history of any other swellings in the neck or elsewhere in the body. There is no history of cough, hemoptysis, breathlessness, or bony pain. She is not a case of diabetes, hypertension, tuberculosis, asthma, or epilepsy. There is no history of radiation exposure in the past. There is no history of drug intake, no history of similar complaints in the past, no history of previous surgeries in the neck. Family history, there are no similar complaints among the family members. She consumes mixed diet, normal appetite, her sleep is adequate, bowel and bladder movements are regular, no substance abuse. Coming to menstrual history, she attained menarche at 12 years with regular cycles of 28 to 30 days without any history of dysmenorrhea, menorrhagia, or passage of clots. Summarizing my history, she is a 42-year-old female hailing from non-endemic area Hassan, came with the chief complaints of painless swelling in the lower part of the neck since 2 years and has gradually progressed from 2 centimeter to the present size of 5 cross 5 centimeter with no other swellings elsewhere in the neck, with no history of fever or weight loss, without any features of hypothyroidism or hyperthyroidism, without any pressure symptoms.
Okay, before we go to the
Martin, audio ಸ್ವಲ್ಪ ಸರಿ ಕೇಳಿಸ್ತಿಲ್ಲ ಅಂತ ಚಾಟ್ ಅಲ್ಲಿ ಬಂದಿದೆ ನೋಡಿ ಸ್ವಲ್ಪ.
Sir, Savitha ma'am has 2 devices connected, sir. As Savitha and Savitha KS, she can just close one, sir.
Samsung. This is the other one. Is this
Ma'am, we
clear?
can. Ma'am.
Okay.
Yes, ma'am. You can just try talking now, ma'am.
Is it clear now?
Yes, yes.
Yes, ma'am.
So before we move on to the physical examination, why did you ask for history of pain and fever?
History of fever to rule out any other causes of swelling like lymph nodal enlargement in case of tuberculosis, which is the most common cause of neck swelling in India. And history of pain is also for the same, any acute enlargement of or infective pathology.
Tuberculosis as such, what is the most common lymph node involved in tuberculosis?
Sorry, ma'am.
The most common lymph node in the neck involved in tuberculosis.
Lateral neck lymph nodes 2, 3, and 4.
So it is a rare thing.
Vulvodigastric.
For midline lymph nodes to be involved is rare, right?
Yes, ma'am.
Then what are the menstrual irregularities you expect in a thyroid swelling?
In case of hypothyroidism, there will be menorrhagia. In case of hyperthyroidism, there will be oligomenorrhea and amenorrhea.
Good. Okay. Continue.
Deeksha?
Yes, sir.
Hello? Deeksha?
Yes, sir. Yes, sir.
Can you go back to the first slide? Can you go back to the slides?
Yes.
Still, okay. You told that, yeah, chief complaints. The swelling in front of the lower part of the neck.
Yes,
Where
sir.
exactly in the lower part of the neck? It's actually a wide area, the lower part of the neck.
In the
Or should be more
involving the left side of the midline, sir.
Right, it's closer to the midline. Because
sir.
the differential diagnosis for the lateral part of the neck swellings is entirely different from the midline swellings. So when you're presenting chief complaints, that you should take care of that, whether it is in the midline or the lateral part of the neck. Okay, next slide.
Yes, sir.
This is the other device, sir. It's Samsung. The first device I have closed now. Other device, sir. Yes. Oh.
So, Deeksha,
Yes, sir.
a patient may not be able to tell the size of the swelling so exactly. So
Yes,
it's
sir.
better to keep it as a rough size, like a small size of a peanut or something like a lemon, just progress to the present size. That will
Yes,
be
sir.
a better answer for this. Next
Yes,
slide.
sir.
So there is no history of pain. Where exactly you asked for the pain, this patient?
Pain over the swelling, sir.
You mean to say over the swelling in the neck, lower part of the neck? What will be the reasons for pain in that swelling?
So there can be, in case of capsular stretch or recent hemorrhage in case of thyroid swelling, recent hemorrhage, and
Okay.
nerve infiltration.
Which nerve infiltration will cause this? Which nerve infiltration?
So sensory fibers of recurrent laryngeal nerve.
No. That is a very rare condition where you don't get this CS or that involving the nerve tissues there. The most commonly will be itis, inflammation, thyroiditis. Most commonly what we get is
causes.
Yeah, benign causes are more commonly associated with the thyroid swellings, which causes pain. What is the reason to ask for fever?
So to rule out tuberculosis or lymph nodal enlargement in case of Hodgkin's lymphoma, which can cause Epstein fever.
Any other reason?
Any infective pathologies or
Like?
superadded infections.
Like, for example?
So acute bacterial thyroiditis, chronic bacterial thyroiditis can also cause fever.
Okay.
Acute bacterial thyroiditis can preceded by upper respiratory infection with a fever.
Okay. You're asking about the compressive symptoms. I assume that there is no history of difficulty in breathing and stridor is compressive symptoms. Can you name some thyroid disorders which cause this? Most common thyroid disorders which may cause these compressive disorder.
So multinodular goiter, Riedl's thyroiditis, and anaplastic carcinoma.
Anaplastic carcinoma is a very rare entity. Rather than that, what you told was a long-standing multinodular goiter.
Multinodular goiter, yes.
Retrosternal extension. Retrosternal extension is the other, which will cause difficulty in breathing for the patient. Anything else? Benign conditions where the patient will get difficulty in breathing. Can you think of? Primary thyrotoxicosis. You know the reason for difficulty in breathing in primary?
Because of cardiovascular component, there will be
congestive cardiac failure, because CCF, congestive cardiac failure, can present with difficulty in breathing in a patient of primary thyrotoxicosis. So what is the reason for hoarseness of voice here?
So again, involvement of recurrent laryngeal nerve.
No, involvement of recurrent laryngeal nerve will be a very rare condition here.
And
are you thinking in terms of
vocal cord edema in case of hypothyroidism?
Yeah, hypothyroidism, there can be a, what will be the deposition there?
So glycosaminoglycans.
Glycosaminoglycans deposition may cause hoarseness of voice. Okay, next slide. Can you tell me the most common symptom of an hyperthyroidism? Most common symptom what the patient will come with in hyperthyroidism?
Swelling, sir.
No, in hyperthyroidism.
Hypo.
I'm not talking about primary or secondary thyroiditis, just hyperthyroidism. Most of the time when the patient comes to the OPD,
and tachycardia, there will be eye signs.
So those are the late features. Usually what we identify is the loss of weight. Loss of weight in spite of a good appetite. That will be the most common symptom in hyperthyroidism. Do you know where else we get this symptom? Any other disease?
Adrenal.
No. Most common, what we see in our day-to-day practice.
Yeah, most commonly day-to-day, we see most of the patients with that. Loss of weight in spite of a good appetite.
Losing weight.
Yes.
Polyphagia, losing weight, not taking clue.
Diabetes mellitus.
Yeah, most commonly it's in diabetes mellitus. So these are the two conditions where the patient is eating more, still losing weight. Okay. Okay, why did you ask for this cough, hemoptysis, breathlessness?
Sir, considering malignancy, to rule out any metastatic symptoms, I just asked, sir, because it is a long-standing swelling since 2 years.
Yeah, there are only named 4 malignancies in the thyroid, and you should be more specific in your history taking about how they spread and what will be
Yes.
the type of symptoms they are presenting with. Okay.
Yes, sir.
If it is a follicular, what will be the symptom? Follicular carcinoma.
Sir, they present with neck swelling followed by, because of metastasis, there will be pulsatile bony metastasis.
Yeah, pulsatile bony
Slight-
metastasis over.
Leading to
Scalp.
slight swelling. Yes, sir.
Okay, correct. Next slide. Yeah. What is the age of the patient?
Sir, 42 years, sir.
So you asked about the radiation exposure in the past.
Yes, sir.
How past it is and how it is significant here in the past system.
Sir, when in childhood, if the patient is exposed to radiation, in the long run for 8 to 10 years, there will be development of papillary thyroid carcinoma. But sometimes the risk can even increase up to even up to the age of 50 years.
Okay. So the patient age should be less than 20 years before he was exposed to the radiation. And from there, after 10 years of exposure, patient may have a chance of developing what type of cancer?
Papillary thyroid carcinoma.
Papillary thyroid cancer is the most common thing. Do you know any ways where the patient can be exposed to the radiation earlier days? Any different ways?
Hodgkin's lymphoma. Earlier, they also used to give low dose radiation for tinea capitis, even for thyroid, adenoids, and acne. So that also will increase the risk.
Now the risk rate is decreased because
Yes, sir.
Repeated CT
Yeah,
scan.
the management strategies have changed for other benign disorders.
yes. Yesterday staying also we have the protections from thyroid disorders. We have protection belt for the thyroid disorders where we don't expose the thyroid usually when we are giving a radiation. Okay. No history of drug intake. What drugs you asked for particularly?
Sir, few drugs can cause hypothyroidism, like if the patient is on antithyroid medications or iodine-rich drugs like amiodarone or PAS and perchlorates, lithium.
So the one is anti-arrhythmic, Moderators,
Amiodarone,
lithium,
antipsychotic lithium, yes, sir.
anti-tubercular, then anti-thyroid drug, which also causes swellings. Okay, you remember those things. No history of similar complaints in the past. Means, why do you ask that?
So swelling in the neck, if to rule out recurrence of the similar swelling in the same site, sir.
Which thyroid swelling will have recurrence?
Sir, if it was a malignant and there was a residual disease and if it recurs.
Means you have done a hemithyroidectomy and it recurs. Something like
Yes,
that.
sir.
So,
Or if she was on any other medication before and the swelling would have recurred.
it is very uncommon to have that sequence like that. Okay, when you are done in a subtotal thyroidectomy and left out for a total for a multinodal goiter, you have done a subtotal thyroidectomy. Earlier we used to do that, and small volume of the tissue is left out, then there can be a recurrence. That is a rare entity. Okay, next slide. Family history is very important here.
Yes, sir.
So, what are the most common thyroid disorder which runs in families?
So, familial non-medullary thyroid cancers can be present in Cowden syndrome, FAP.
No, the syndrome. Okay, syndromes are very rare. Like, what is the most common disorder which runs in families? Most of them will have hypothyroidism.
Medullary thyroid carcinoma.
No, carcinomas are very rare. Less than 3% have chances of carcinomas. Any deficiencies?
Same food is shared between the family members.
Sir?
Same food is shared between the family members.
This thyroid
iodine
peroxidase enzyme
deficiency.
deficiency is the most common
What-
disorder which runs in families. Should keep. Even Graves' disease runs in families,
Yes, sir.
and other carcinomas are next. Okay, so you should have a
Yes, sir.
detailed history of having relatives with thyroid disorders and any hypothyroidism which is running in the families. Okay,
Yes, sir.
next slide. Okay, next slide. Next slide. Next slide. Next slide. Okay, after you have somebody. What about the obstetric history?
Sir, there was no history of miscarriage or repeated abortions. She is B2, L2.
Is it important in a case of thyroid swelling obstetric history? Is it important?
Yes, sir.
How?
Sir, because hyperthyroidism can cause repeated abortions and infertility and miscarriages.
Infertility is caused by both hypo as well as hyperthyroidism.
Yes, sir.
Both may cause infertility, but the risk more will be with hyperthyroidism, where the patient will go for other complications like preeclampsia, abortion, early abortions, more common with hyperthyroidisms.
Yeah.
Okay, after the summary, what is your diagnosis?
What is the most common
Sir,
diagnosis you made?
because it is a solitary thyroid nodule, and it can be a dominant nodule of a multinodular goiter also.
Now, how will you come to the diagnosis that it is a thyroid swelling?
Sir, because it is based on the location of the swelling, it is in the front of the neck and in the lower part in the midline. So it is in the thyroid layer region.
Yes. Which gender is more common to have thyroid swellings and why?
Female gender is more common because of increased expression of estrogen receptors.
Emotional susceptibility and increased exposure with the hormones will result in thyroid disorders in the females. So it is a female sex. If you are presenting, if you are giving a diagnosis, you should tell some points towards your diagnosis when you are presenting a case at the end of the summary, like a female patient, 45-year-old patient presenting with the midline swellings in the center, slowly growing swellings without any features of pain or fever. So all these points goes in favor of a thyroid swelling. And also the most common swellings in the neck in the midline swelling will be a thyroid swelling.
Thyroid.
Can you give some of the differential diagnosis for that? Midline swellings. I mean to say midline swellings.
Yes, sir. It could be subhyoid bursitis, dermoid cyst.
Yes.
It could be a thyroid swelling, lipoma in the central part of the neck, thyroglossal cyst.
So those are the differential diagnoses, but you can rule out with the history that it is a non-toxic solitary nodule of thyroid, which can be a most common probable diagnosis from the history. Okay.
Yes, sir.
Yes.
What is a solitary nodule?
Sorry, ma'am.
Can you define solitary nodule of thyroid?
It is a discrete nodule which is palpated on an otherwise normal gland.
So can you give that diagnosis on the history?
With, it is, yes, ma'am. There is a single
So-
swelling.
Yeah. So probably thyroid swelling is the only thing you should be telling, isn't
Yes,
it?
ma'am. Yes, ma'am.
Okay, let us proceed.
Shall I proceed, sir?
Yeah, go to the
Yes.
general physical exam.
So, I have examined the patient in a well-lit room after taking informed consent with adequate exposure and adequate privacy. Patient is conscious, cooperative, well-oriented to time, place, and person. She is moderately built and nourished. Her BMI is 23 kg per square meter. She is afebrile. Her pulse rate is 86 beats per minute in right radial artery in supine position, regular in rhythm, and good in volume and character. Her blood pressure is 110/70 millimeters of mercury, and her respiratory rate is 16 cycles per minute. On 2 examination, there was no loss of hair noted, and no eye signs pertaining to hyperthyroidism or GIMS disease. There is no facial puffiness or flushing or peripheral loss of eyebrows noted on the face. On examination of tongue appears to be normal. There is no twitching or fasciculation or macroglossia. The palms are soft with no moistness or dryness. There are no tremors. No thyroid acropathy, no edema or peritibial mixed edema noted. Coming to local examination, on inspection, there was a solitary swelling in the anterior aspect of the lower part of the neck in the thyroid region, measuring 6 x 5 centimeter in the left side, vertically oval in shape, superiorly extending 2 centimeter above the thyroid cartilage, inferiorly 1 centimeter from the sternal notch. Medially, it crosses 2 centimeter beyond the midline towards the right, and lateral border is ill-defined. Lower border is visible, surface is nodular, it moves up with deglutition but not with the protrusion of the tongue. Skin over the swelling appears normal, no engorged veins or visible pulsations noted, no other visible swellings in the neck. Trachea on inspection appears to be central. On palpation, there was no local rise of temperature over the swelling. Swelling is non-tender. The swelling is noted in the anterior aspect of the lower part of the neck in the thyroid region, measuring 7 x 6 centimeter towards the left side, extending behind the sternocleidomastoid muscle on the left side. Superiorly, it is 2 centimeter above the thyroid cartilage and inferiorly 1 centimeter above the sternal notch and 2 centimeter lateral to the midline on Lahey's method. Surface is nodular, firm in consistency. It moves with deglutition. Lower border is palpable, and the plane of the swelling is deep to deep cervical fascia. Skin over the swelling is pinchable. Trachea is deviated to the right on palpation. Carotid pulsation is felt on both the sides. Cervical lymph nodes are not palpable. There was no thrill felt on the superior pole of the swelling. On auscultation, there is no brew audible at the upper pole of the swelling. Coming to systemic examination, both the first, second heart sounds are heard with no murmur. Bilateral normal vesicular breath sounds are heard. On CNS examination, there was no neurological deficits. Deep tendon reflexes are normal. Per abdomen, soft and non-tender. There was no organomegaly or no ascites noted. Summarizing, she is a middle-aged female with swelling in the anterior aspect of the lower part of the neck in the thyroid region, which moves up with deglutition, which is vertically oval in shape, measuring 7 x 6 centimeter with well-defined lower border, nodular in surface, firm in consistency, deep to deep cervical fascia with no features suggestive of hyperthyroidism or hypothyroidism with no compressive symptoms.
So, go to your first slide of your this examination.
Local examination. Local exam.
Okay. What was the position of the patient?
So,
When
patient
do
was
you-
in a sitting position. On inspection, her neck was extended. On palpation, the patient was in a sitting position and neck flexed.
Neck flexed. Okay, good. Why do you need to flex the neck?
To relax the muscles.
What is the plane of the thyroid?
Deep to deep cervical fascia.
Good. Go to the next slide. Next slide. Why have you specifically mentioned that lower border is visible?
No, in case of retrosternal extension or retrosternal goiter, the lower border will not be visible. So to rule out retrosternal goiter.
Good. Okay, next slide. Go to next slide. Next slide. Okay, what are the other methods of examination?
One is Lahey's method. For short neck patients, Pizzilo's method is used, and to examine the nodularity, Kreil's method is used.
Okay. Where did you feel for the carotid?
This is a one-sided swelling involving the isthmus. So, how did you do the Lahey's method?
Sir, I stand in front of the patient on to examine the left border. I push the right side of the swelling towards the left, and with the help of right hand, I will examine for the margins and surface on the left side.
Yeah. Basically, you want to look for the nodularity and the borders, right? So, okay.
Yes, sir.
Where do you feel for the carotid pulsations?
Upper border, medial to the sternocleidomastoid muscle at the upper border of the thyroid cartilage over the C6 vertebra. Buccal of C6 vertebra.
Okay.
C6 tubercle is exactly at this thing, cricoid level, not upper border of thyroid cartilage. You are feeling the carotid pulsation. Bifurcation is at the upper border of thyroid cartilage, what you are saying. So carotid tubercle means the sixth cervical vertebra is at the cricoid cartilage level.
Yes, sir.
Deeksha, in general physical examination, what are the things you are examining in the hands of a
Yes,
thyroid
sir.
patient? Hands of a thyroid patient.
So tremors, and I touch the patient's hand to feel if there is any moistness or dryness.
Okay. Anything else? What are the other things you
And
see? One is
hoarseness or
moistness. Give a handshake and see for the moistness.
Temperature,
yes, sir.
warmth,
And if the palms are soft or coarse in texture.
Yeah, skin. Skin is warm, coarse texture. Then what about the fingers? Nails.
So nails, we will observe to see if there is any acropathy changes.
Acropathy. And about the pulse. What about the pulse?
Pulse, sir.
yeah.
Pulse, so in case of hypothyroidism, there will be bradycardia. In case of hyperthyroidism, there will be tachycardia. And rhythm will be irregular.
So
Sometimes
rate,
collapsing pulse may also be elicited.
no, there will be changes in the rate, rhythm, volume,
Rhythm.
character. All these things has to be defined when you're taking the case of thyroid, because all these changes in case of hyperthyroidism as well as hypothyroidism. Okay. Why thyroid moves with deglutition?
Sir, because it is attached to the trachea by condensation of the pretracheal fascia, Berry's ligament, and the staph muscles are attached to the oblique line of the thyroid cartilage. So whenever there is deglutition, along with the laryngeal apparatus, the thyroid also moves.
That is one of the reasons. Any other reason? No. Posterior condensation of the pretracheal fascia, which forms the Berry's ligament, which is attached to the cricoid cartilage. That is one. Yeah.
Yes, sir.
Have you
The
heard about
muscles which are attached.
pretracheal fascia? Attachments of the pretracheal fascia.
To the oblique line of thyroid cartilage.
Yeah, it will be a single layer at the oblique line of thyroid cartilage. It comes downwards, splits into two. It encloses the thyroid gland, goes down and attaches where? Inferiorly. Okay, there are four
Open or
reasons why.
attached to something?
Not sure.
There is no bony attachment downwards. It condenses around the connective tissue of the arch of the aorta around the neck. So when thyroid moves, cartilage moves, thyroid cartilage moves, which pulls the pretracheal fascia, so it also moves. Okay.
Yes, sir.
Basically, there is an inferior constrictor, thyropharyngeus and cricopharyngeus. They pull the laryngeal cartilage up to allow the foot to the esophagus. So during that time, the pretracheal fascia, which is a buried ligament, attached up to the laryngeal cartilages. That also is contributing to the movement up with the deglutition.
Which carotid pulsations you can palpate?
Common carotid.
What about the internal carotid and extra carotid?
Sir, there is no tubercle, it cannot be palpated against heart structure. So external or internal is not normally felt.
The only carotid which can be felt is the common carotid arteries. Okay. And the surface you are told as nodular.
Yes, sir.
What is your diagnosis?
Sir, a non-toxic multinodular goiter involving the left lobe and the isthmus without any compressive symptoms.
Deeksha, that video of the patient with the, that one is there? You can run that video. Better visible that swelling. Turn laterally this one. What happened?
I'm not able to play the video. Sir.
What happened?
No, sir.
That would have been much more informative. Okay, no problem. No.
So what is your diagnosis?
Non-toxic multinodular goiter involving the left lobe and the isthmus with no compressive symptoms.
How will you proceed now? How will you proceed?
Ma'am, to confirm my diagnosis, I would like to do biochemical investigations. First, FT3, FT4, and TSH, followed by ultrasound of the neck to see the size of the nodule. And it is a single swelling. So to rule out, if I'm not sure if it is multinodular based on clinical examination only. So to see for other nodules in the neck and to see for any other features like involvement of lymph nodes. And to stratify the risk in the ultrasound, I would, based on the features, to see if it is a malignant nodule or a benign nodule, followed by if it is turned out to be a high risk feature, then I will go ahead with the FNAC.
So Deeksha, your diagnosis is actually multinodular goiter, isn't it?
Yes, ma'am.
Yeah. So what you are trying to see on the ultrasound will not be like nodule. You are telling I want to see a nodule. No.
Ma'am,
You
it
are
is
seeing
already
multiple nodules.
to see if it is multifocal, like if it is involving, because it might change the management, if it is involving the other lobe also.
Yes. You want to see involvement of the other lobe.
Other lobe, yes, ma'am.
Yes. And
high risk features in the ultrasound to risk stratify in case if it is a malignancy.
okay, what are the high risk features you will be looking for?
Ma'am, it involves looking out for a composition if it is a solid swelling, And in echogenicity, if it is a hypoechoic, and calcification, mostly a microcalcification, and followed by irregular or margins or extrathyroidal extension, and taller than wider nodule.
Right.
Mostly suggest that they are high-risk features.
Okay, what is the risk of malignancy in a multinodular goiter?
It depends on if it is solid or cystic. In case if it is a solid swelling, the risk of malignancy is 12%, and for cystic swelling, it is 6%. And again, based on whether the patient is male or a female, the risk of malignancy in a solid nodule will decrease to 6% in case of female, and it increases to 24% in case of male. And for cystic swelling, the risk decreases to 3% in females, and it increases to 6% and 12% in males.
What malignancy will develop in a multinodular goiter?
Sorry, ma'am?
What malignancy will develop in multinodular goiter? In a
What
multinodular
type of
goiter,
malignancy get it?
what type of malignancy will you get?
Follicular thyroid carcinoma.
Correct.
Okay. Okay. So you do ultrasound
Yes, ma'am.
and there are no features of suggestive malignancy. Next,
Yes,
what will
ma'am.
you do?
FNAC, because the size of the nodule is more than 2 centimeter, I would like to do FNAC.
Okay. So you want to do
Anything
plain.
you have for that FNAC?
Sorry, sir.
It's a multinodular goiter. You want to do a simple FNAC or anything?
No, if the thyroid TFT is normal, then there is no need of other investigation. I can go ahead with FNAC, sir.
You always do a ultrasound guided FNAC. Give a correct picture.
Okay, sir. Yes, sir.
Sometimes may hit a cyst, so you may get only fluid. No, that's why it is always image guided is better.
Image guided. Yes, sir.
If it is cystic,
Yes, ma'am.
what part of the nodule will the FNAC be taken from?
FNAC will be mostly taken from the internodular tissue, which are active.
Yes.
Solid component.
Solid component should be taken. Okay, next what will you do?
So, again, if FNAC, there is a stratification based on Bethesda classification. So if the swelling turns out to be non-diagnostic, then a repeat FNAC is done. If it turns out to be a benign swelling, the risk of malignancy is just 0 to 3%. So no further investigation is required. Just follow-up is advised. If it is atypy of unknown significance, or a follicular lesion of unknown significance, or Bethesda 4, which is a follicular neoplasia, then either molecular testing or lobectomy can be done just to confirm the diagnosis and to proceed further. And Bethesda 5 is suspicious of malignancy. The risk is more than 50 to 75%. So surgery, and Bethesda 6 is malignant lesion. So both Bethesda 5 and 6, I would like to do definitive surgery.
This is a 7 centimeter lesion. You want to avoid surgery or you want to are planning for a surgery?
Sir, planning for surgery, sir.
Usually molecular testing is needed in this case.
No, sir. Only in case of
The patient doesn't
funny
want
with
surgery
variation of-
and it wants to be clear, sure whether it's malignant or benign. In that case, sometimes molecular testing for small lesions they do it. Okay.
Yes.
What are the indications, what are the treatment options for a multinodular goiter?
Ma'am, surgery, and the surgery is based on surgery
Only surgery?
to prevent
Why surgery?
complications like toxicity. To prevent complications like toxicity or carcinoma in the long run, and sometimes pressure symptoms also.
What
Only
are the indications for surgery in multinodular goiter?
Sir, one is to prevent the complications, like there
What
can be secondary toxicosis in multiple goiter,
multinodular goiter may
followed by
not grow at
in
all.
long run.
It may not grow at
Sorry,
all.
sir.
Multinodular goiter may not grow at all. It may just remain the same. This
But
patient
there is
doesn't
a
have
risk of
pressure symptoms,
malignancy.
doesn't have hyper or hypothyroidism. The
It
patient
is
comes.
sir.
What is the
The
indication for surgery in multinodular goiter? There are clear indications. Anticipating pressure symptoms and operating is not correct. Then we have to operate every thyroid coming to us. That's why sir asked what are the other treatment options available for this patient.
Sir, since the swelling is very big, 7 x 6 centimeter.
We have seen much bigger swellings, madam. I will tell you one thing. Cosmesis is the primary reason for surgery in multinodular goiter because it is obvious in the neck, na?
Yes, sir.
Cosmesis is the main reason. This patient doesn't have pressure symptoms. It looks
Yes.
odd. Many people will question the patient. Cosmesis is one reason. There are patients where we give 50 micrograms of thyroxine for 6 months trial we give. Unless there are ultrasound findings of thyroid 3, 4, 5, where FNAC or nodal metastasis or distant metastasis, or where FNAC is indicated, and based on the FNAC findings, we advise surgery. Just a colloid nodule or multiple colloid nodules, no radiological suspicion areas, cosmesis becomes the first important thing, and pressure symptoms if they are present.
Yes, sir.
They won't grow. Thyroid swellings don't grow overnight. Even to grow a few millimeters, they will take a year or more. Okay, don't panic when the thyroid patient comes to you. We were taught like this: cosmesis, pressure symptoms if they are present. Otherwise, there is a trial option, just that the patient may have iodine deficiency. Treat the iodine deficiency. Also, you can give a trial of 50 micrograms, not more, for 6 months only. We don't give beyond that. There are many of our patients with multinodular goiters whom we have kept on follow-up only. Not as big as this, but if 7 to 6 centimeters, if it is not causing any pressure symptoms, mainly breathing symptoms, we want to operate. Okay.
In the long
If it's
run, there is
causing
a
pressure
small
symptoms,
risk of secondary toxicosis or malignancy. Malignancy is so low that it is
for
around
that we keep them on
15%.
follow-up, sir.
Yeah, you can
We keep them on
follow up.
follow-up 6 months. 6 monthly follow-up, we keep them. If they want surgery or for cosmetic reasons, we do.
Yes.
Yeah. Main thing is follow-up is a challenge in our country. And many times what happens, FNAC comes benign. After 2-3 years, it comes malignant. We have seen so many patients. So patient has to be on follow-up if they want to go for a conservative treatment.
Any patient kept under observation, they have to come for follow-up. Unfortunately, in India, even oncology patients also don't come for follow-up.
True, sir.
Reliability is very important. We must call them. We keep a directory. Call them and ask them to consult. Otherwise, they can go for surgery.
Agreed, sir.
If a surgery is, are you discussing about surgery now?
So what surgery you are planning?
What surgery?
Sir, if the other lobe is not involved in the ultrasound, I would like to do hemithyroidectomy.
Any other options?
Hartley-Dunhill's procedures.
Hmm?
Hartley-Dunhill's procedure. So to prevent the risk of injury to recurrent laryngeal nerve and parathyroid injury, I would like to conserve the other part of the gland if it is normal.
No, one lobe you understandable. If it is not involved, we won't touch it. But
Yes,
if there are nodules
Yes,
in the
sir.
other lobe also,
Then probably
see,
total thyroid.
difficulty of redoing the surgery,
Yes, sir.
risk of injury to recurrent laryngeal nerve is more. If you should not dissect on the other lobe, if you are not going to touch it. Otherwise, the scarring may make the surgery difficult. If there are nodules in the other lobe, anyway, rather than giving 50 micrograms of thyroxine, you can as well give 100 micrograms or whatever. But we didn't get to see the ultrasound report in this patient. Did we discuss that?
It's there, sir. Ultrasound of neck shows features suggestive of colloid nodule with internal cystic degeneration in the left lobe of thyroid. It is thyroids 2, sir.
What is the size in the ultrasound?
3.6 into
3.6 into 2 centimeter in the left
You
lobe.
have, there are multiple nodules.
Multiple nodules, not just one.
Clinically also it was obvious that it was not a single nodule.
Yes, sir.
Okay. So you may feel it as 7, but you felt multiple nodules means it is a multinodular goiter.
Yes,
Okay.
sir.
So with this 3.6 into 2 multiple nodules,
Yes, sir.
the risk is that they may develop nodules in the other lobe unless you treat the reason for it, usually iron deficiency.
Yes, sir.
Any lymph nodes?
No, sir. No evidence of enlarged cervical lymph nodes.
No. So is the examiners accept that surgery is the treatment?
Surgery is the treatment, but sir, if it is a multinodular goiter, then it is better to tell a near total or total thyroidectomy. And if it is solitary nodule thyroid, then it's better to tell a hemithyroidectomy, benign conditions. Because the subtotal thyroidectomy and Hartley-Dunhill is not done nowadays, I think. So.
See, our experience with recurrent laryngeal nerve injury is very, very less.
Yes, sir.
Recurrent doesn't get damaged even when it is being divided also, because it's involved in papillary carcinoma, we have repaired it.
Yes.
Generally, they recover by around 6 months.
Yes, sir.
So, parathyroid is an issue. Even if we have put enough effort, also 1 to 2% patients may develop permanent hypoparathyroidism. Means not even one gland being preserved. Even if one gland is preserved, permanent hypoparathyroidism doesn't happen.
Yes, sir.
If 2 glands were preserved, hypoparathyroidism doesn't happen at all. One
Yes,
gland is preserved because the vascularity is so small, the blood vessels are less than a millimeter. So even if you have preserved the parathyroid with intact blood supply, the coiling or the twisting can
Yes, sir.
affect the blood supply and the gland may go for necrosis after you close the neck wound also. When the muscles fall back in place. Okay. So we try to preserve all the 4 glands for that reason. Recurrent laryngeal nerve in benign conditions is not a difficulty at all.
Yes, sir.
In malignancy, you do also central node dissection also, no, sir? That's the reason probably parathyroid injury is more in. Hello?
Yes, sir.
Yes,
Yes,
sir.
sir.
Sir,
Got disconnected.
Take some questions from the chat box.
Yeah.
Yes. Shall we go to the chat box questions? So the first question is Deeksha, will you please answer these questions from the chat box?
Yes,
So
ma'am.
the first question is what is Pemberton sign? from Dr. Chandrashekar. Madam has asked you.
Yes,
Can you please answer that?
Yes, ma'am. It is seen in a retrosternal goiter. The patient is asked to raise the arm over the head and to keep the arms close to the ears. This will cause engorgement of the veins in the neck. This is because of obstruction of the thoracic inlet and causing venous obstruction by the retrosternal goiter.
Good.
Is there any particular change in deep tendon reflexes in thyroid disorder?
Yes, ma'am. In case of hypothyroidism, the relaxation of deep tendon reflexes will be delayed.
What is quadruple assessment?
Clinical examination, history and clinical examination, followed by biochemical assessment with FT3, T4, and TSH, followed by ultrasound and cytology if anything.
Correct.
Correct. So, what is nerve of Galli-Curci?
Curci. Amelia Gallicus. Ametia, no?
Ametia Galli-Curci.
Ametia Galli-Curci.
He is the person, he was an opera singer. So, who had, it was claimed that after surgery, he had difficulty in taking high pitches.
Which nerve is called?
It's a lady.
Recurrent laryngeal.
Okay.
External branch.
High pitch is the nerve to
Sorry,
precothyroid.
external
External
branch
laryngeal.
of superior laryngeal.
External branch. External. Superior laryngeal. External branch of superior laryngeal.
Timbre of the voice will go. The pitch of the voice.
Pitch of the voice.
I think we have answered. This has been discussed. What is the role of genetic testing?
In very small nodules and familial malignancies, if the patient is not willing for surgery, molecular testings mutations can be tested, like 7-gene panel or mRNA expression or liquid biopsy.
So we
with the
have
permission
two
examiners.
surgeons here. Can you just throw some light on how do you preserve all the parathyroids? What are the precautions you take? Because recurrent laryngeal now most of us see, but the parathyroid is one thing, and when it really happens, hypoparathyroidism, it's very difficult to manage. Can you throw some light on this, sir?
Can I say, madam?
Yes, please.
In benign things, the capsule is not infiltrated. If you stay subcapsular and take care of only the branches which supply the thyroid gland. So what we do is we don't ligate the inferior thyroid artery at all until we have preserved the parathyroids. Or we don't ligate the inferior thyroid artery as such. We generally clip the inferior thyroid artery branches to the thyroid and don't ligate the superior pedicle first. We dissect the inferior thyroid artery branches, preserve the blood supply to the parathyroid, and clip the blood vessel supply to the thyroid, all the individual branches. Some of the branches will be, the recurrent laryngeal will be traveling in the fork between these branches. In the process, we use the fine bipolar tip. We use a 0.5 millimeter tip of bipolar, 5-inch long. It is available generally with Valley Lab. So when we have preserved both the parathyroids intact with the blood supply, after that we ligate the superior pedicle and then take the ligament of Berry. In the process, what happens is that if you have ligated a superior pedicle, the gland is reflected, the lobe is reflected forwards, and it may act as a traction on the blood supply to the parathyroid. So preserve the parathyroids with intact blood supply, drop them down. Don't allow your attender or assistant to use suction there. Use a 3 mm suction in thyroid surgeries. We don't allow anybody to use suction there. Wet gauze or sometimes warm saline gauze is used to gently tap on the parathyroid so that they are not pressed with much pressure. So the attempt is to preserve all 4 parathyroids. Only when we do central neck dissection, sometimes we may not be able to preserve the inferior parathyroids. And inferior parathyroids, they can vary in position from anywhere in the lower pole, behind the lower pole, or in the superior mediastinum also. The number of parathyroids can vary from 4 to 20. 12 to 24% of them time they are intrathyroidal. So when it's intrathyroidal, you can't preserve. But if you preserve one lobe of the thyroid, two parathyroids are definitely preserved. So there is no risk of hyperparathyroidism. We don't even do calcium tests also. So if all the four parathyroids are preserved, total thyroidectomy is done, we send a parathyroid hormone assay same day. By 2 hours or something, we get the report. In Bangalore, it is possible. So if it is low, we start the patient on calcium infusions directly. If it is normal, then we don't give any calcium infusion. Even if we are doing central neck dissection for very early stage thyroid cancers, we try to dissect only on the side of the disease, the central neck, so that the parathyroid on the other side will not be affected much, unless you feel any abnormal lymph node on the opposite side of the central neck. That's how we preserve. And at the end of the dissection, the inferior laryngeal node, the recurrent laryngeal node, will be related to the parathyroids as an invert percentage sign. Means the superior parathyroid will be in front, behind the nerve, whereas the inferior parathyroid will be in front of the nerve. That's how we generally, when we see the nerve, we look for the inferior parathyroid at around the lower border of the thyroid lobe or just behind the lower border. The superior is generally constant. It is at the junction of the upper third or the middle third of the posterior border of that lobe of the thyroid. So that's how we have to identify them, preserve with their intact blood supply. Parathyroids are tan color, covered by a small cap of fat, to which the blood vessels enter.
Thank you.
One more
Dr.
thing to
Sudesh, sir.
add, ma'am.
Good evening, sir.
From the use
Dr.
of
Sudesh, sir.
monopolar cartridge, the use of monopolar cartridge and
evening.
bipolar cartridge. Hello?
Yes, sir.
The use of cartridge, ma'am, the use of cartridge should be avoided in these areas. That will be helpful.
Yeah, bipolar cut.
No, we use
Bipolar. We should
bipolar
use
only
bipolar.
to dissect the capsule. For the blood vessels, we don't use bipolar because after you have used bipolar, it falls down. Then the spurt may start. To control the spurt, we may end up damaging the blood
That is
supply.
the problem.
And if there is any spurt from one of the branches, the blood supply to the parathyroid will be compromised because of this bleeding. So clipping is more important. We use 100 clips. Neurosurgeons, particularly, I think this. There are some companies which manufacture 50 size clips also. 100 is blue, 200 is white. If we want very fine blood vessels to control very fine blood vessels, we use that yellow colored clips come from a different company.
So how much it costs, sir?
No, these clips cost around 200, 300 rupees per cartridge, around 6. There are some cheaper companies also, but they will give a longer cartridge with multiple clips. So hospitals re-sterilize and reuse them.
Okay.
Ethicon comes with only 6 clips per cartridge.
Okay.
But they don't have the 50 size clips. Neurosurgeons preferably use those clips, and we use it for thyroid and parotid surgeries.
Okay, sir.
Shall I add?
Yes, sir. Yes, sir. Please, sir.
I think very good points, inputs from experts. I appreciate as far as the technique is concerned, and parathyroid is one thing we should always preserve. We need to identify the parathyroids early enough to preserve it. Best is to not to handle it, as been told. But bipolar, by and large, if you apply it on the thyroid gland, instead of going towards the parathyroid, one can, and you, there was an apprehension by Dr. Shashi telling there could be a possibility after the parathyroid drops down, there can be a bleeder. So the chances of that is very remote because these branches, what we are coagulating between the thyroid and parathyroid will be very fine branches, and they easily get controlled in case even if it start oozing, a dry gauze, if it kept on that, it will stop. That is one way. I agree that after it drops down, if you try to catch with a energy source, there will be a chance of devascularization. That is one aspect. So in such a rare event, you can always harvest the parathyroid. I'm sure Venkat would be able to tell, or Rashikar would be able to tell how to implant and where to implant, how to take care of that. That is one aspect. The other aspect is bipolar is quite a safe option. You need to have a right setting where you can minimize, and there is a way how you have to use it with the water droplets dropping on it. It will be more effective. Lateral thermal spread can be minimized, not because of the moisture, because the bipolar becomes that much effective, and that will consume less energy to coagulate the same vessel. And you can use that with a little traction. You can always separate the tissues also. So bipolar is not just a coagulator, but it is a dissector, I'm sure. And last, a word about these clips. They are not freely available in all hospitals. Unless you have got your own hospital, you can recommend, you need a special clip applicator for open surgeries. So it is not the lab clip applicators you can use, because you cannot stabilize the long length of clip applicators in open surgeries. So that is cumbersome, and you will not apply properly. You need to use clips with clip applicators. So these clip applicators are, when you use different size, you need to have a different size clip applicators, open clip applicators. So you should know about it. So if you can afford, and most importantly, I would like to say, it's a time that general surgeons, when you do thyroid surgery, start using magnifying loops. So that is one small tip I wish we are getting used to these loops, operating loops. Generally, for your regular operative work, if you start using a small 3x, 4x, 5x, even if it is 3x, it is quite good. I don't know how you put it across. Venkat, do you use loops routinely?
So far, I am not using any loops. So maybe because of my myopia, my near vision is not much affected. So at the end of surgery of parathyroids, it's described that the blood supply drops to 1/3, which many of us don't know, because of the spasm of these small muscular arteries. So we try to do some jugaad, like pouring some warm saline, xylocaine plain 2%, little quantity on the parathyroids, so that it causes some vasodilation and keeps the blood supply intact. If there is a confusion between a lymph node and a parathyroid, say, thinking it is devascularized, the lymph nodes don't turn black when they are devascularized, whereas a parathyroid is usually spherical in shape or ovoid, unlike a lymph node which is bean shaped. The parathyroid can turn black when it is devascularized. So then we take it out, put it in saline, using 11 number blade, we make 1 millimeter slivers. Through those slivers, then we implant generally in the sternomastoid itself, unlike the textbook description of forearm, because to put another incision in the forearm is again cosmetically may not be good. Whereas sternomastoid, once we implant it inside the muscle, multiple slivers, the percentage of these auto-transplanted parathyroids recovering is not more than 50%, maybe around 25%. Not all will recover. So finer pieces must be made and implanted to, in case of any future malignancy or tumors developing from these parathyroids, for safety, we clip that area or we use a Prolin stitch in that area for future reference.
Role of ICG, sir.
I don't have experience. Dr. Jaka may have experience with ICG. Some people have used methylene blue. That methylene blue is picked up by the parathyroids. So we have not used it. Generally, if at all it's used, it is used for a primary hyperparathyroidism or adenomas. Jaka has more ICG.
See, majority of the times we have found that, as Siddesh sir was telling, if you go in a false and true capsule plane, medial towards the thyroid with bipolar, we are able to preserve parathyroid. We are able to see the parathyroids. ICG we have used, but I have not found any advantage over the normal surgery. So we have done many cases and there is no difference.
Okay. I think we'll move on to the second case.
Okay.
But excellent
Thank you, Dr.
presentation.
Deeksha.
Yeah, excellent presentation. I appreciate the clarity and the preparation of Dr. Deeksha. Yeah, congratulations.
Congratulations, Dr. Deeksha. Sir, she agreed for the presentation when we met her at the NSD meeting. So she hardly had 4 days time.
Yeah, short time.
That's
No.
very short time. Yes.
You are final year student, Deeksha?
Yes, sir.
Yes, they are prepared like a student. You give them a case, within 5
Yes,
minutes,
that
they
is-
should be
they
ready
should.
to present.
Yes.
And I appreciate it. Mentor, you are from which college?
Yes.
Sir, Hassan Institute of Medical Science.
So I congratulate the mentor, I think Ravi,
Dr.
here,
Ravi.
who has prepared her well.
Yes, sir.
So that's it.
Yes.
Thank you.
Thank you, sir.
Thank you. Yeah, good.
Thank you, Deeksha. And
Okay.
thank you everyone who has participated in the discussion. After our extensive discussion on multinodular goiter, we'll go to the second case presentation by Dr. Vishal. Dr. Vishal?
Yeah, yes, ma'am.
Yeah. So please present he is from GIMS. So he'll be presenting a case on right buccal mucosa CA. Vishal, you can go ahead
Yes,
with your
ma'am.
presentation.
Good evening, everyone. Good evening, respected staff. I'll be presenting a case. Here is a 55-year-old male who hails from Shivaji Chowk, Basav Kalyana, who is a farmer by occupation. He came with the chief complaint of growth in the inner aspect of right buccal mucosa since 1.5 month. I'm sorry, one slide is missing, ma'am. Then notice I'll directly come to the HOP here. Then he noticed a growth in the inner aspect of right side of a cheek, which was insidious in onset and rapidly progressive in nature. Initially, growth was 1 x 1 centimeter. Now progressed to a current size of 4 x 3 centimeter, not associated with pain. He had a history of halitosis and no history of bleeding from the lesion, no history of excessive salivation, no history of difficulty in swallowing, no history of difficulty in opening mouth, no history of difficulty in protrusion of tongue. There is no history of ear pain, no history of multiple sexual contacts, and there is no history of recent loosening of teeth, and there is no history of trauma from the sharp tooth, no history of swelling in the neck, no history of cough or a hemoptysis, no jaundice, abdominal distension or bone pain, no history of loss of appetite or weight loss, and is not a known case of hypertension, diabetes, or any comorbid conditions. Past history, there was nothing significant, and no significant family history. Personal history, he consumes mixed diet, sleep is undisturbed, appetite is adequate, bowel and bladder is normal. Habits, he's a Gurkha chewer since 25 years. He is approximately consumes 5 packets per day. Summary, a 55-year-old male patient with complaints of rapidly progressive growth in the inner aspect of right cheek since 1.5 months, associated with halitosis with history of tobacco chewing since 25 years. Shall I proceed, ma'am?
HOPI, please. History of presenting.
Sir, this slide has been HOPI, some correction.
Yeah. Next. Why difficulty in swallowing in buccal mucosa?
Sorry, sir.
Asking all the adenic symptoms is not necessary. You
Okay,
can
sir.
understand bleeding, salivation, trismus. Okay, swallowing doesn't happen here.
Yes, sir.
Okay.
Extension of
For a
tumor
lesion
into
which
this.
is and the size also again we have been taught not to mention the size. Small in size, gradually increase to present size.
Okay, sir.
Okay.
Okay, sir.
Next. What is this history of multiple sexual contacts?
Sir, I wanted to rule out any HPV related infections.
HPV related oral cancers or
Oropharyngeal carcinomas are more common.
That's why.
Yes.
He is a good guy. If he doesn't have any other positive, etiology, why to ask it, isn't it? If you asked, then you just don't mention it. In case if somebody asks, you mention it. Okay.
Okay, sir.
Why jaundice, abdominal distension, bone pain? I can understand. Bone pain also in buccal mucosa usually doesn't go to the lymph nodes itself first. Tongue is different. Oropharynx, hypopharynx are different. Buccal mucosa going to the lymph nodes usually happens when there is a muscle or skin involvement, not the mucosa. This is our observation and reported also. Generally doesn't go to the lymph nodes easily. Okay.
Okay.
Yeah, you can say difficulty in
Yes.
chewing, etc.
Chewing.
can happen because of mandible involvement.
Yes, sir.
Okay, and difficulty in protrusion of the tongue also happens when there is tongue involvement. Before that, there should be dysarthria.
Okay.
Okay, for that lesion, it should involve the mandible, flora of mouth, and then go to the tongue. It cannot directly go to the tongue.
Tongue, sir.
Okay. So jaundice and abdominal distension generally doesn't happen in head and neck cancers unless there is a lung metastasis already.
Hematogenous spread to rule out hematogenous spread. Yes.
Hematogenous goes to lungs and then goes to the liver.
The liver, sir.
It cannot go to the liver directly.
Yes,
Although I have seen one case of pyriform fossa going to the
first
liver directly, it's very unusual. Okay.
Yes, yes.
Pyriform fossa is different. So oral cancers don't go to the liver directly unless there is a involvement of lungs. Okay.
Yes.
By that time, the patient won't survive.
Oh.
Okay. So yeah, you can continue. Anything from the examiners?
What is the significance of this pain? You were telling about this pain.
Sir, there is no history of any pain, sir.
Okay. How does the pain radiate to the ear?
Sir, involvement of lingual nerve, sir, through
So for the involvement of lingual nerve, it has to involve the flora of mouth. It has to cross the mandible.
Mandibles.
See, the mandibular branch also supplies the ear.
Yes, sir.
Ear. Okay.
Yes.
The tympanic branch of the mandibular nerve supplies the deeper, that is the tympanic membrane. There can be referred pain through that. Auriculotemporal nerve supplies the external ear, so there can be pain referred to the pinna.
Yes.
Glossopharyngeal nerve, Jacobson's nerve. That is the tympanic branch of the glossopharyngeal nerve. If there is oropharynx involvement, there can be pain referred to the tympanic branch of the glossopharyngeal nerve. So that is a deep-seated earache.
Yes, sir.
If there is involvement of neck nodes and through the cervical plexus, if the greater auricular nerve is involved, there can be pain referred to the lobule, ear lobule. Okay.
Okay.
Right.
And one more thing is about halitosis. You told halitosis. No, what is the reason for that?
Sir, there is a tumor necrosis, sir. Secondary to that, there will be bacterial infection leading to release of sulfur contents like butyric acid, ammonia, leading to halitosis.
Also, you may not brush the teeth properly because of the
poor oral
hygiene.
Tumor necrosis is bacterial infection, and also there is a food debris may get
logged.
Poor hygiene. All these causes this sulfur compounds to get accumulated and result in foul smelling breath.
Yes.
Why excessive salivation?
Sir, due to chronic irritation of nerve endings, sir, and inability to swallow the saliva.
Usually common in this tongue.
Yes, yes, sir.
The negativity you should have mentioned about white patches or something like that, white patches or red patches in the
to rule out leukoplakia and erythroplakia. Yes.
Generally, gutka chewing, cheek, they keep it in the cheek.
And gingival.
There will be SMF, submucosal fibrosis, and leukoplakia to start with.
Yes.
And then it becomes also.
Do you know what is the difference between like pre-malignant lesions and pre-malignant conditions?
Yes, sir. Pre-malignant lesions are lesions from where generally carcinoma arises. Pre-malignant conditions are generalized conditions where a tumor can occur at any sites.
So give an example for that.
Sir, leukoplakia, erythroplakia, and oral submucous candidiasis, sir. Candidiasis, sir. Are pre-malignant lesions, sir.
Yes. How do you differentiate this candidiasis patch from leukoplakia?
Sir, leukoplakia, we cannot slough, the whitish patch cannot be sloughed out, sir. In case of oral submucosal hyperplastic candidiasis, sloughing can be done.
You told about the habits.
Yes, sir. Yes, sir.
What do you mean by quit?
Sir, it is a combination of betel nut, slack lime, and betel leaves.
Areca nut. Yeah. What does it contain and how does it cause this? How it is a carcinogen?
Sir, arecolin promotes fibroblast proliferation and causes malignant changes, sir.
These nuts, they contain this arecolin and tannins. These
Tannins,
arecolins will cause stimulation and proliferation of the fibroblasts.
Yes.
Collagen synthesis will occur, whereas these tannins, what they do is stabilize
the fibrins.
Yeah. So the collagenase will not act, so there can be a proliferation, continuous proliferation leading to cancers. You can continue.
Sir, general physical examination. Patient was taken consent, sir, with due consent. Patient was conscious, cooperative, and oriented to time, place, and
Can you
person.
skip this, sir, for want of time?
Skip, sir.
Nothing much contributed. Can you skip this?
Yes, sir.
And we can go to local examination.
Yes, sir. Inspection on local oral cavity examination. On inspection, lips and commissures were normal, sir. Mouth opening was adequate. Inter-incisional distance was 42 mm. And buccal mucosa, a solitary ulceroproliferative growth of size 4 into 3 cm in the right buccal mucosa, extending anteriorly 1 cm posterior to the right commissure of lip, superiorly 1 cm from the upper GBS and inferior till the GBS, sir, and posteriorly extending up to the third molar teeth. And everted margins, edges were there, and irregular margins noted. And left buccal mucosa was normal. And teeth, dental staining noted with the loss of second molar teeth, sir. And gingival and gingival sulcus was normal, and tongue was normal, and gums were normal. Here is a dental formulas. And oral cavity examination, floor of a mouth was normal. Rest all things were normal. Retromolar triangle was normal. Hard and soft palate was normal, sir. Oral cavity examination on palpation, there was no local rise of temperature or tenderness. All inspectory findings were confirmed. A solitary ulceroproliferative growth of size 4 into 3.5 centimeter in the right buccal mucosa, extending anteriorly 1 centimeter posterior to the right commissure of lip, superiorly 1 centimeter from the upper GBS and inferiorly till lower GBS, and posteriorly extending up to third molar teeth. Edges were everted and irregular margins were noted. And induration present up to 0.5 centimeter from the margins all over the direction and doesn't bleed on touch. And bidigital examination of mandible, there is no involvement of mandibular bones. Retromolar trigone was normal, and tongue movement was normal in all the directions. And on neck examination, no cervical lymph nodes were palpable, and cranial nerve examination was normal. And all the systemic examination was normal. Provisional diagnosis. Here is a 55-year-old chronic tobacco chewer since 25 years with rapidly progressive ulceroproliferative growth on the inner aspect of right cheek of size 4 into 3.5 centimeters since 1.5 months with associated halitosis. I would probably it could be a carcinoma of right buccal mucosa with clinical staging of T3, N0, and M0.
Can you go to the inspection, please?
Yes.
See, when we inspection, what we start is lips and commissure correct.
Yes.
Mouth opening second. Third is halitosis. Once they open the mouth, halitosis should be mentioned immediately after that. Then the dental hygiene. Then the lesion.
Okay, sir.
Okay. If
Okay.
you have written already inferior GB sulcus is involved, then you should, the next slide, you should not write GB sulcus is normal.
Okay, sir.
Go to the next slide.
Sir, on the opposite side, I meant,
So
sir.
you should be clear. If it is already mentioned, don't mention that again. It is normal.
Okay, sir.
Then, as it involved the gingiva, that is more important. When the GB sulcus is involved, whether gingiva is involved, whether there are loose teeth.
Yes, sir.
Okay. Loss of lower to molar to teeth means there must be extension to the gingiva. Otherwise, the teeth won't go just like that. Okay.
Yes, sir. It was on the opposite side, sir. The lesion was on right side.
Okay, right.
There was loss of teeth on the right side, left.
Go to the palpation slide.
Depth, did you mention roughly? Skin involvement, you said. Induration 5 centimeter, 0.5 centimeter from a margin in all directions.
Sir, I could feel the induration, sir, but depth, I couldn't.
Depth, it is not quite easy because the disease is growing laterally.
Yes,
the
sir.
base is laterally. So unless the buccinator is involved or something, then that you must assess. The skin and fat may be free,
Yes,
but
sir.
there will be extension to the muscles. Okay.
Yes.
Plus, it is a deeply invading tumor. You may not be able to mention in this case. Tongue you can mention,
Yes,
but not in buccal mucosa or palate. Okay. Then next. Anything from the examiners? Any questions they can ask?
Can you tell me the classification of the TNM?
Yes,
T
ma'am.
classification.
Yes, ma'am. T1 is less than tumor size less than 2 centimeter and depth of invasion less than 5 mm. T2 is T2 2 to 4 centimeter with the depth of invasion less than 10 mm, and tumor size of less than 2 centimeter, depth of invasion more than 10 mm, and T3 2 to 4 centimeter with a depth of invasion of less than 10 mm, and T3 with tumor size of more than 4 centimeter with depth of invasion less than 10 mm. T4 will be invasion to the surrounding structures, no? And T4 will be invasion to the pterygoids, retromoral trigon.
That's T3.
Yes, ma'am.
You have mentioned in your diagnosis that it is T3.
Yes, ma'am.
So, how did you arrive at that stage?
Ma'am, depth of invasion I couldn't appreciate, ma'am, but we are through follow-up of investigation, radiological investigation, will assess.
No, listen one thing. When in doubt, always understage.
Yes, sir.
When in doubt, always understage. Don't overstage. Okay.
Okay, sir.
Because the stage 2 becomes stage 3, patient will also panic.
Okay, sir.
Pathological stage is actually the correct one, but when in doubt, always understage, because radiological investigations will not reveal the exact depth, because when they scan the patient's mouth is either closed or their puff cheek this thing, the scan is taken. Okay, and CT scan will not reveal the exact depth. MRI has to be done. If there are folds, then the depth will be more.
Yes, sir.
So 2 to 4 centimeters tumor, this is less than 10 mm depth.
Yes, sir.
Comes as T2.
T2.
And in cervical lymph nodes not palpable, the better terminology is to write no cervical lymphadenopathy. Okay. Palpable, not palpable becomes like a layman term. You can write no
cervical lymphadenopathy.
So there is one more thing in buccal mucosa, what you should always write: paramandibular soft tissue involvement.
Okay, sir.
mandible to
Yes,
the
sir.
left, to the side of the mandible, lateral aspect of the mandible, the upper 1 centimeters or more than that, there should not be any tumor, presence of tumor.
Yes, sir.
Why?
Sir, for treatment, sir, for surgery, if it is nearer to the mandible, we have to get marginal mandibulectomy, sir. If it
See,
is abutting
if
to
there
the
is
mandible.
paramandibular soft tissue involvement, means you cannot preserve the mandible.
Yes,
You need 1 centimeter height of the mandible,
yes, sir.
either from the lymph node, submandibular node, or from the buccal mucosa tumor. If there is paramandibular extension, you cannot preserve the anything
Mandible,
less
sir.
than 1 centimeter. If you preserve the marginal by doing marginal mandibulectomy, there can be fracture later. So always this you should see that paramandibular soft tissue involvement. One, if the disease is not touching the GB sulcus, it is less likely that paramandibular soft tissue is involved. If the disease is touching this GB sulcus, that means there is possibility of it involving the paramandibular area.
Okay.
There are also trials now. If there is paramandibular tissue extension, try to give neoadjuvant therapy. Pathological complete responses are very few, hardly 5%, but clinical response in around 30 to 40% of the patients. There may be an option of preserving the mandible if there is a paramandibular soft tissue involved, depending on the extent of involvement by giving neoadjuvant therapy. Okay.
Okay. Okay.
Next slide. Okay. Did you try to gauge the extent depth of the ulcer?
Yes, ma'am, I tried, ma'am. But
Okay,
due to
what-
induration, I couldn't.
What method did you use?
Ma'am, I tried to palpate the ulcer by digital examination.
By manual, you should use 1 digit. It's not easy.
Yes.
2 digits from the same end. It's not easy to examine. It will cause more discomfort. So you can use bimanual examination and see if there is any deeper information.
Okay.
What are the things you look for in mandibular examination?
Sir, to look for the mouth opening, adequate mouth opening, sir. To look for any.
But when you do a bidigital examination, what are the points you should look for? One is the tenderness.
Tenderness, yes, sir.
Irregularity, thickening, and any
Yes.
fracture sites that should be seen when you're examining the mandible. What is the importance of this retromolar trigone assessment?
Sir, if it is involved, then it is a advanced carcinoma. Sir. It can
How can it become advanced just because retromolar trigone is involved? It cannot.
If
cannot. There is a different reason when retromandibular trigone is involved or RMT. Your approach changes. The treatment approach changes for a different reason.
It can involve a pterygoids.
Mandible early.
Yes.
It's very difficult, no?
Yes.
To save the mandible because there is not much of muscle in that area. The lesion rests almost very close to the
mandible
coronoid process. If the disease only for margin purpose, you can remove the coronoid.
Yes.
That is called as coronoid, this thing, mandibulectomy. Okay, coronal mandibulectomy, marginal mandibulectomy. So if you have to remove the coronoid process for the sake, but if the disease is invading deeper, so then we have to be careful because the next limit will be the masticator space.
Yes.
Masticator space, the pterygoid space will be involved. So it's very critical area. Generally, if the retromolar trigone is involved, there can be extension to the infratemporal fossa. We must do an MR to check whether there is extension to the retromolar trigone, risk of involvement of inferior alveolar nerve, and mandibular foramen ovale at the skull base. Widening has to be looked into because the disease can spread perinaturally.
Yes.
Even when there is mandible body involvement, mandibular canal involvement, also we must look for perineural spread to the skull base. MRI is the tool.
Yes.
CT scan cannot help.
And also, you're not examined for the TMG joint.
He said mouth opening is okay.
Otherwise, okay. Can you examine, how will you examine for the joint?
Sir,
Behind the pinna, you can palpate for the joint.
yes,
Even the movements.
movements can be felt, sir, at the angle of the mandible, sir, behind, in front of ear pinna.
Yes. Okay.
What next?
Sir, we'll manage, sir. We'll go with the routine blood investigation to and to confirm my diagnosis, sir.
Why
And
routine blood investigations?
First confirm the diagnosis, no?
Confirm
yes,
the
sir.
diagnosis. When it comes to treatment only, you need blood investigations. You can
Yes.
do as part of the anesthetic checkup. Confirm and stage the disease and treat according to the stage.
Okay, sir. To confirm my diagnosis and to stage the disease, sir. To confirm
Because
my
practically
diagnosis.
speaking, a buccal mucosa patient coming to me, I don't send them for any blood investigations.
Yes,
I do the
first we'll
biopsy
get
first.
biopsy, sir. Yes, sir. We'll do veg biopsy, sir.
And punch biopsy also can be done.
Yes. And to stage the disease, we'll get a CCT head and neck, sir, and USG neck and HRCT thorax, sir.
CT scan for soft tissues is not as unless you are looking for the bone involvement. Always you can add a MRI and CT
MRI,
complement.
Yes.
If the lesion is limited to buccal mucosa, you can easily feel the upper lower areas of the buccal mucosa are free. Then there is not much need for imaging unless there is a deeper tumor. Okay.
Yes. As it was near to the mandible, sir, so I thought there would
CT
be
also in academics there is no financial discussions that come.
Yes, sir.
Okay, affordability should not be discussed at all. So you can always say CT and MR.
MR.
Because MR can also appreciate the lymph nodes better. No?
Yes, sir.
Okay. What tests were done? Please, punch biopsy or wedge biopsy?
Yes, sir.
Wedge biopsy, whenever you take, you will have to take a stitch. Punch
Yes,
biopsy,
sir.
you don't have to take a stitch. Okay.
Yes. Sir, a specimen of edge biopsy for growth in a right buccal mucosa was taken, sir. On gross examination, specimen consists of.
Just tell
Yes, sir. It was a well differentiated squamous cell carcinoma, which is a keratinizing type.
Well differentiated will always be keratinizing. Poorly differentiated will have less keratin.
Less keratin. Yes. And this is a CCT head and neck, sir. Suggestive of a neoplastic etiology, which 33 into.
How come there is size difference? Your examination, you would have used a paper scale or a wooden scale, never use a metal scale, it will hurt.
Yes,
paper
sir.
Scale would be better.
Okay. Sometimes a tumor cannot take contrast.
No. Always clinical examination is more accurate in visible lesions. Okay.
Yes, sir.
Right.
And there was a focal loss of intervening fat plane between lesion and the overlying skin along the right cheek, sir. Suggestive of skin infiltration.
Clinically, you didn't have skin infiltration, right?
Sir, no, sir. There was no skin infiltration.
So
Extra oral examination was done.
Your examination is more accurate.
Yes, sir. And there was no there was minimal extension of right retromolar trigone, sir, and right buccinator muscle was noted. But on clinical examination, retromolar trigone was intact, sir.
That is more. You should know the boundaries of retromolar trigone for that.
Yes, sir. So here I can look, sir.
Yeah, it's very much clear. When the patient's mouth is closed, they may not be able to appreciate. Probably they are not done with the puffed cheek position.
Yes.
Okay. Lymphadenopathy?
Sir, there was no any lymph nodes involved. USG next, sir.
Why did you use USG when there is CT scan already done?
Sir, actually there was one feeling one lymph node 1 × 1 centimeter on the right side. I wanted to confirm that, sir. In
neck, 1 × 1 centimeter lymph node is not a significant node unless it is rounded or
it was
fixed.
Yes, sir.
Contiguous areas, right?
Yes, sir.
Yeah,
no, you have already told CT scan. You should not tell again ultrasound of the neck.
Okay, sir.
The
Why
CT
did you
scan
do
is a
what
higher
is
investigation.
Yes, sir.
what is the advantage of ultrasound? Sometimes we do ultrasound. What is the advantage? See, ultrasound has a much higher resolution.
Yes.
There are 4 findings in ultrasound which can be suspicious of a metastatic node. If there is hilar fat obliteration, there are hypoechoic areas inside the lymph node. That means necrosis, tumor can
Necrosis.
be there. There can be a rounded node instead of a bean-shaped node, and extranodal fat
Extension.
stranding. Yeah, fat stranding if it is there. So if these things are there, they can do a USG guided FNAC.
Yes.
Okay, right. So what next with this finding?
Sir,
Mandible is free, right? No involvement.
yes, sir.
So paramandibular soft tissue also is free.
Yes, sir.
And what next now?
Sir, we'll go with sir, staging here. They didn't give any depth of invasion, sir.
Let's still know. Ultimately, your clinical examination will decide your treatment. Pathologist will give the final pathology.
Final, yes, sir. So I'll go with the wide local excision of the primary, sir, with the 1 centimeter
We'll
of
have to counsel
margin.
the patient first, work up the patient, counsel the patient for surgery.
Yes, sir.
Okay, explaining what you are going to do for the buccal mucosa, for the neck, and the reconstruction. Okay.
Yes, sir.
Now tell what are the
Sir, for tumor, we'll go with the wide local excision of
okay, good.
1 centimeter margin, sir.
Margins all around, correct.
All
Deeper
around.
also,
Yes,
360
sir.
degrees. Okay.
Yes,
Then
sir. And we'll with this selective neck dissection, sir.
what selective neck dissection would be?
Supraomoid neck dissection, sir.
Okay. What is
Level
neck dissection?
1, 2, and 3 lymph nodes will be removed.
For the sake of sometimes nodes to be on safe, we remove the level 2A nodes, lymph nodes above the spinal accessory nerve in level 5. That is, if at all there is any metastatic node in the neck later on in the pathology report,
Yes,
the maximum risk of involvement of the lymph nodes will be above the spinal accessory,
yes,
not below the spinal accessory. So we clear some lymph nodes in the apex of the posterior triangle also.
okay.
What we approach, and that is recommended.
Yes.
Generally, buccal mucosa, as I told you, doesn't go to the lymph nodes. In case if one lymph node is involved, if we have cleared the level 2 lymph nodes, then there is no need to give radiation to the neck unless there is extranodal extension. Okay.
Yes.
Extranodal extension is a requirement for chemotherapy and radiation both.
Yes, sir.
But the stage changes. You mentioned T stage, you didn't mention N stage. N stage, less than 3 centimeter node with extranodal spread is a different stage. Okay.
Yes.
Okay, got it.
Yes, sir. Yes.
So you have done surgery, you have removed the lymph nodes. What next?
And now we'll do reconstruction of the defect, sir. With the PMMA flap.
Would reconstruct.
PMMC flap is not recommended for buccal mucosa of this for the surgery that you have done.
Or yes.
What other better flap is available?
Sir, nasolabial flap can be taken, sir.
Nasolabial also for this defect, no, it will be less inadequate. It will be less because you are removing a 4 centimeter into 3 centimeter tumor. Expect the defect to be 6 into 5 centimeter.
We can take anterolateral aspect of thigh flap also.
Better one. Much better. Anterolateral thigh flap, there are two problems. Bulky. It's because lateral aspect of the thigh, there will be more fat. Second, there will be these perforators are short and sometimes their vascularity is questionable. Means there may not be adequate vascularity. Which other better one is available? If somebody is a executive working in a company, he doesn't like to wear sleeves shirts, the radial artery forearm flap is avoided and flap can be taken from lateral aspect of the arm or from the anterolateral thigh, okay, with the microvascular blood supply and then do a microsurgery.
Okay.
So for this patient, the pliable, soft, faciocutaneous radial artery forearm flap is the ideal flap. When there is bulk, the flap will sit in the cheek. Now the bulky flap will give a big bulge on the cheek. Cosmetically, it won't look.
No. And post-operatively, we'll give radiotherapy, sir.
Hey,
After
don't
the surgery.
just like that, man. Based on what are the indications of radiation post-operative period, you must know.
Yes.
Don't fall into the pit, dig your own pit. Okay, don't do that. What are the indications for radiation? If you know the indications of radiation, you have to accordingly you have to communicate. What are the indications for radiation?
Sir, if there are significant nodal involvement, sir. And
I have already answered it. You should be more clear now.
sir, if there is a positive margin, sir, extranodal invasion, sir.
See, primary tumor, nodal status, both are considered separately. If it is primary tumor, T3 and above.
Yes.
T3 and above, positive margin. What is positive margin?
Even after surgery, there.
For radiation. Positive margin is microscopically positive margin. Closed
Yes.
margin is anything less than 5 mm is considered as closed margin, inadequate.
Yes.
If there is only one margin, you can always revise it rather than giving radiation. So generally we keep 1 centimeter margin so that microscopically there is more than 5 mm margin. Okay. So that is the depth, primary tumor depth. Beyond what depth do you consider for radiation?
Sorry, sir, I didn't.
See, primary tumor size, T3 and above.
Yes, sir.
Those are positive margins. Third is
Yes.
the depth. Depth of the tumor also dictates radiation, adjuvant radiation. What depth?
More than 10 mm.
10 mm.
4 mm, sir. 4
mm
mm.
also is an indication because the risk of micro lymph, you see, you're removing the primary tumor, you're removing the lymph nodes. In between tissue, you're not removing. Means the transit lymphatics will be there.
Yes, sir.
So the lymphatic emboli risks are more. If there is lymphovascular emboli, worst pattern of invasion is high. Even then, there is an indication for radiation.
Radiation.
Risk of recurrence increases.
Yes.
When it comes to the lymph nodes, one lymph node involvement is not an indication for radiation. If you have done adequate nodal clearance, the minimum of 10 lymph nodes removed. For staging 6 is enough. For therapy, 10 nodes. That with proper SOHND, you will get 10 nodes. If there is extranodal extension, closed margins, positive margins, it's an indication for neoadjuvant, adjuvant radiation. 2 or more nodes also is an indication for radiation. So 1 node, extranodal spread, 2 nodes or above is an indication for adjuvant radiation. And if there is this other things for the primary tumor, we have already told you. These guidelines are very clear. You must mention the reason for chemotherapy. I told you positive margins and
Yes,
extranodal extension. Or concurrent chemotherapy with cisplatin for weekly is given during radiation. Adjuvant radiation is generally 60 grays.
60 to 66.
Means around 2 grays, 1.8 to 2 grays per fraction. So 60 grays means it will be like 6 weeks of
6 weeks.
So anything? Jaka, examiners?
Already 10 o'clock.
No, people are still there. The number of people who have logged were less, but still they are there.
Yes.
Anything to add?
There are a few questions from the chat box, sir. We'll take them.
Please,
There are
please.
no any questions from the examiners.
You can stick.
There is one question. Does your orocutaneous fistula change the T stage?
Yes, obviously. Skin involvement is T4. Bad things to manage. Once there is orocutaneous fistula means the cutaneous and muscle involvement width increases. Tumor can spread along the muscle planes. Dermal lymphatic emboli can be there. There is a high risk of nodal metastasis. Also, after surgery, there can be recurrence in the local area of the face or in the neck lymphatics. Neck lymphatics means even in the dermal emboli in the neck skin can come up. Ideal indication for neoadjuvant chemotherapy if there is skin involvement. When there is fistula involvement, we can't give chemotherapy in the presence of a fistula because the patient cannot eat well. We'll have to put a PEG tube and give feeding while the patient is on therapy. So you can, if the lesion is not having much of dermal lymphatic infiltration, redness, flared areas, you can still consider for upfront surgery. But skin involvement is not a good sign in any oral cancers.
Thank you, sir. Thank
Any
you for
other question is there?
role of USG guided FNSC in case of lymph nodes of the neck.
Yeah, unless it's only for the initial staging purpose. These also, if there is one positive node, you can go for a modified neck dissection 1, 2, not 3. Sternomastid is not preserved in those cases. If there is already a positive lymph node on FNSC documented before surgery. So instead of staging neck dissection, it will be a therapeutic neck dissection. Generally, there is no radical neck dissection when the vein is radical neck dissection is generally done when the vein or spinal accessory nerve or both are involved. When they are free, we generally don't touch them. We try to preserve them because we need the vein for the microvascular flap.
Thank you, sir.
Okay.
Any questions from the examiner?
Nothing specific.
Thank you everybody for the opportunity. I thank Dr. Siddesh and Dr. Savitha Karlwad, Dr. Naz. Thank you everyone.
Thank you, ma'am. Thank you for joining in, and thank you for your insightful inputs. Thank you, Dr. Vishal. It was a very good presentation from your end. And I thank all the examiners, Dr. Ravi, Dr. Savitha, madam, and Dr. Shashikumar, sir.
Thank you.
Thanks, madam.
Thank you.
Thank you, everyone.
Good night.
Yeah,
Service,
Dr. Nath,
sir?
comments from Chairman, madam.
Yes, sir.
Hello, Dr. Nas.
Yeah, I'm here. Yeah, it was an extensive discussion. Both the cases went on very well. And congratulations to Dr. Deeksha and Dr. Vishal Patil for an excellent presentation. And the examiners, thank you, Dr. Shashikumar, Dr. Savitha SK, and Dr. Ravi. And I really am grateful for a short notice. You have really prepared the students so well, and the examination went on good. And thank you, Dr. Venkatachala and Dr. Rajshekar Jaka for the expert input. And thank you, Dr. Siddesh, for joining in, and all the EC members, all the students, and all the members of the KSCASI. Thank you for joining in. And over to Dr. Sarvesh for the vote of thanks.
Yeah. See, it started 8 days back. Because before we had fixed, all got cancelled. And because of the conferences we had and Surgeons Week, we couldn't do in the second Thursday as fixed. And because of the TISA also, we can't do it on Thursday for another 1 month. So with the short notice, we discussed with Dr. Ravi, HOD HIMS. He agreed with the student. Thank you very much, sir.
Thanks, sir.
For arranging the things, and to your PG also. And I contacted Dr. Sangamesh, and he also obliged, and the Buccal mucosal CA came from his side only, Dr. Vishal Patil. Thank you, Dr. Sangamesh and Vishal Patil. I thank our moderator, today's moderators, Dr. Savitha K and Dr. Chandrashekar for moderating the session, and the examiners, Dr. Ravi S, Dr. Savitha SK, and Dr. Shashikumar. Shashikumar also I contacted, and Savitha also. They also agreed. And it was a nice examination also for the PGs with the inputs from Dr. Venkatachala. Thank you, sir.
Thank
Dr.
you.
Jaka, and our past and Social Welfare Council Director, Dr. G. Siddesh, sir. I thank all our EC members, all the participants and PGs, and we have MidCon in August. If you are not registered, register now. And for the paper presentation, poster presentation also, we have extended the date till 30th of this month. So make use of it. It's in Surya. It will be a nice one. So thank you one and all. Good night.
Thank you, sir.
Thank you. Thank you. Good night.
Good night. Good night.
Good night, sir. Thank you very much.
Yeah.